So today, guys, we're going to talk about other codes. Codes that are other than diagnosis. So that's what we're going to talk about today. We're going to talk about signs and symptoms and also external causes of morbidity, and I will explain to you what those are. Okay, so without much further delay, let's go to our discussion for today. Okay, signs and symptoms. When we talk about signs and symptoms, we are talking about manifestations of an underlying condition, right? So that's something that doctors always need to watch out for because according to the signs and symptoms, doctors make their decision what patient may be having. At the moment, if a patient goes to the clinic or the emergency department, doctors always look for those signs and symptoms because they want to know what is really going on with the patient. If a patient has abdominal pain, if a patient has chest pain, what is the underlying condition behind that chest pain or abdominal pain. So those are signs and symptoms. And you guys already know what signs and symptoms are, right? And the difference between signs and symptoms. When you talk about signs, um, these are manifestations or patients that are revealing or patients are showing, but you know. Like I said, it's because of an underlying condition. But when you talk about signs, these are things that are visible, right? Patients are showing signs which the doctor can see, right? Example, if a patient has sort of like imbalance, like or patient is not able to talk or having some difficulty in speech, those are signs, things that are visible from the vantage point of the other person. Now, when you talk about symptoms, these are things that are not seen. Okay, patient are patients are able to experience that or feeling or having these types of say sensation or numbness or like pain. The doctor cannot see pain. That's the reason why doctors, when patient comes in with a pain, doctors would ask or clinician would ask the patient the degree of pain, like in the scale of 1 to 5 or 1 to 10, where is pain? So again, symptoms are things that are not seen by the other person. So the most important rule that you guys need to understand in medical coding is that especially when you talk about signs and symptoms, is that signs and symptoms are not coded if the doctor has a definitive diagnosis for that sign and symptoms. And we have already discussed this, in our previous lessons, in our previous discussions. We know that if there is a definitive diagnosis that the doctor has offered, then of course, we don't assign the code for signs and symptoms. And again, let's go back to the example that I gave earlier, like an abdominal pain. If a patient is coming in with abdominal pain, and the doctor, after assessing, running some tests, the doctor had made his decision that abdominal pain is because of patient having appendicitis. And it's painful, right? So if the doctor said patient has appendicitis, you don't have to assign, as coder, you don't have to assign the code for the abdominal pain. So that's what I meant about if there is a definitive diagnosis, you don't need to assign a code for the symptom. Now, but of course, there are other exceptions that we're going to discuss in a little bit. Now, like what I have indicated earlier, that the most important rule, if not the first, right? the important rule that you guys need to understand about signs and symptoms is that you don't have to assign codes if there is already a verdict or a definitive diagnosis that the doctor had documented. Now, let's move on to the next slides. Okay. Symptoms with definitive diagnosis. Signs or symptoms that are associated routinely with a disease process should not be assigned as additional codes unless otherwise instructed by the classification. I have an example here, dysphagia as late effect of stroke. Dysphagia or dysphagia, whatever you want guys to pronounce that. So let's talk about this, guys. Okay, the guideline here. By the way, signs and symptoms is in chapter. This conversation or this discussion is in chapter 18 of the ICD-10-CM section 1. Okay, so let's break this down. Signs or symptoms that are associated routinely with the disease process should not be assigned additional codes unless otherwise instructed by the classification. And again, the example that I gave here, guys, is dysphagia as a late effect of stroke. Let's talk about that for a little bit. So the guideline is telling us coders that if, like what I have said earlier, if there are already, the doctor had already made his decision that this symptom or sign is because of this definitive condition, then you don't have to assign the codes for signs and symptoms. But there was a disclaimer, a caveat. Unless the instruction, there are further instructions saying that, hey, you can actually assign the code for signs and symptoms. And let's talk about that example that I gave you guys. When a patient, this is very common. I mean, common occurrence when a patient suffers a stroke. Patient may manifest symptoms or signs that you can tell, if you're someone who is, who is related, may not be related or may not be related, but if you're observing the patient and you see that the patient is having difficulty in speech, right? And patient had a history of stroke, and that could be a late effect of stroke, or what we call sometimes, in the clinical term, a sequela of stroke. So the definitive diagnosis that the doctor documented in this instance is that patient has had a stroke, and because of that stroke, patient has dysphagia, right? Dysphagia, guys, is difficulty in swallowing, okay? Difficulty in you know in in taking in food or any liquid or beverage, right? That's dysphagia. Has for some reason, because of that stroke, patient's motor that involves swallowing was affected. Now, the definitive diagnosis there was a history of stroke. Okay, that's the definitive diagnosis. Now, dysphagia is a symptom that a patient had a previous stroke. So we know that we already know that the symptom should not be assigned codes unless, like what the guidelines are saying, that if there was a further instruction that you need to assign symptom or stroke alongside a definitive diagnosis, that's what we're going to do, okay? And this dysphagia, or the difficulty in swallowing, is one of those guys, okay? If you go look at the code for dysphagia because of stroke, let's go back to that slide. The code for dysphagia, okay, because of previous stroke, is this, I-69.391. Now, if you go to the book, okay, go to the tabular section of the book, you will see that there is an additional instruction saying, please specify the the type of dysphagia that the patient is having, okay, because of that previous stroke. And I did not complete the code here because when you go to the code R13.1 and you see this hyphen here saying that you need the last character or the fifth character to complete the code. There are different types of dysphagia, guys. It can be oral, okay? Oral means on, just patients having problem with oral swallowing, right? There is also a dysphagia that's more deep into the patient's esophagus. So that's what I meant about different types of dysphagia. And, when you're assigning a stroke late effect for this particular condition, dysphagia, you will be asked by, or you will be prompted by the tabular to also assign the code to specify what kind of dysphagia it is, what type of dysphagia. Is it only oral? Is it esophageal? Or is it, at the junction of, or mid esophagus? So there are different types of dysphagia that is being described in the book. So that's what the guidelines meant about, yes, it is okay to assign, a code for sign and symptom if, the guidelines or the book or the ICD-10 rule prompts us or instructs us to do so. Okay, so let's go to the next one. All right, so this one is a little interesting, guys. Let's read. So repeated falls. Repeated falls, code 29, R29.6. Repeated falls is for use for encounters when a patient has recently fallen and the reason for the fall is being investigated. Okay, and code Z9181, history of falling is for use when a patient has fallen in the past and is at risk for future falls. When appropriate, both codes R296 and Z9181 may be assigned together. Okay, let's unpack this. This is very important. So this code here, R29.6, the guidelines are telling us that you can only assign this if the recent fall or the reason for the recent fall is being investigated. Okay. Non-trained coders, if you're seeing this for the first time, if you look at the code for fall or falling, right? The first code that you guys are going to see is the R29.6, the one that was shown in the slide. But like I said, a non-trained coder would probably, unknowingly would assign that code because that's what the book is telling them to do or offering them that code. But look what the guidelines say. You can only use that R29.6 if the recent fall that a patient experienced is under probe or under investigation. And why is that, guy? Because we live, in an era where, of course, there are patients who might have experienced accident or injury because of someone has or maybe the environment that the patient is being cared for is not really that conducive to patient care, especially if we're talking about elderly care, right? So that code, the R29.6, is more of like a caution to any coder that, hey, hold on your horses, guys. Don't assign that code unless, okay, that recent fault is being investigated, okay? Because like I said, everything now has to be reported, right? This is the time where the kind of environment that we live in, everything has to be reported. Especially here in this country, guys, we are uh, we are very say we really take care of our elderlies, right? Patient care is, I say, one of the most, how do I say it? We take patient care very seriously, right? If a patient suffers an injury, we take care of our patient. That's our healthcare system here in the United States. So what I'm trying to say is that if the fall is being under investigation, then do not assign that code. I mean, if the fall is under investigation, yes, you can assign that code. But if the fall is not a result of something that is, patient is being neglected, or someone has purposely um, caused the patient to fall, or the living environment the patient is currently in is not conducive to the best patient care, then I mean, the code R28.6 is for that. But if there's nothing mentioned about that, no investigation, no probe, the code that you're going to assign, guys, is, what does the guideline say? This one, Z9181. History of falling, and if patient had fallen in the past, this is the code you are to assign. So be careful with this R29.6, because this is a more appropriate code if there was no investigation of the recent fall that is being undertaken. Okay, so what about this coma? Okay, let's talk about this. Code R40.20, unspecified coma, should be assigned when the underlying cause of the coma is not known, or the cause is a traumatic brain injury and the coma scale is not documented in the medical record. So there is a code, guys, for coma. Okay, there is a specific coma code documentation that would require this R40.20, which in this specific rule here is saying if you don't know the cause of coma, okay, or if a patient has a traumatic brain injury or TBI, and the degree or the severity of coma is unknown, then you can assign that code R40.20. There are many different reasons why patient um, is experiencing coma, right? And the number one reason is a patient had, if I can, make that uh, say assertion that number one reason would be if a patient had traumatic brain injury, right? Traumatic brain injury is if the traumatic brain injury or TBI is so severe, then the patient would most likely experience coma or loss of consciousness, right? So that's what we know about coma. Now, a coma can also be induced, right? So there are people who are or patients that need to be put into coma state because of a certain condition, right? So there are things like those. But from what I understand, which probably I think it's in our slide too, that the coma-induced patient should not be assigned a code for coma scale. Um, so that is the code, guys, R40.20. In fact, okay, so this is the one that I mentioned just a minute ago, saying that do not report codes for unspecified coma, individual or total Glasgow coma scale scores for a patient with a medically induced coma or sedated patient. Okay, I need to put T there. Okay, so it's very clear, guys, that a medically induced patient, a medically induced coma patient, should not be assigned a coma code. And what is that Glasgow coma scale that's being mentioned here, guys? Glasgow coma scale. Every time you see the abbreviation GCS, okay, especially if you're talking about, okay, this is the Glasgow coma scale. They came up with this with this, say, measurement or assessment of how bad the coma is by rating, the patient's responses to certain stimulus, right, or certain commands. That's what the GCS score is about. Now, from what I understand, the lower the GCS score is, I think the GCS score is up to 15, right? 15 would be the perfect, okay? 15 means patient does not have any loss of consciousness, okay? Patient is able to respond to commands, to any stimulus. The patient will have 15. So how do clinicians or say qualified say medical person would conduct this coma scale or this coma test. So from what I understand, guys, how they rate this coma or the GCS score is that they would ask patient if patient is able to open his eyes, or to if a patient is able to follow commands, if a patient can talk, if a patient can raise, an arm or two. So based on those questions, if a patient responds positively, the medical personnel would rate a score. Like I said, the higher the score is, the less severity the patient's being in that state of coma. Okay, so if the score is really low, like in 5 or 3, that means to say patient's almost like non-responsive, right? So that's what we call that's what the GCS is about. So where is this GCS being reported, or being solicited? Let's go to other slides here. Okay, coma scale or GCS score. Let's read. The coma scale codes can be used in conjunction with traumatic brain injury code. Okay, we already know that coma can be attributed to traumatic brain injury. Now, the coma scale code should be sequenced after the diagnosis codes. Of course, we don't assign coma scale as our first listed or a primary diagnosis. There has to be a code for the injury first before you assign the GCS score, right? Now, these codes, one from each subcategory, are needed to complete the scale. The 7-character indicates when the scale was recorded, and the 7 characters should match for all 3 codes, which means that, hey, when you're assigning the code for the GCS score, you need to look at the timeline. When was this GCS score assessed? Was it when the patient, when the first responder, for the most part, guys, when the patient becomes unconscious and someone sees the patient unresponsive, right? So someone will call 911, and the first responder will go to the site and facilitate this test, this coma scale test, right? So as coders, if the timeline is documented, then you are to assign the coma scale according to the timeline. Was it when the first responder arrived? Okay, was it during transit, right? Or was it when the patient got into the ER? They conducted the coma scale. The GCS assessment. That's what the guidelines are trying to say to us, that you are to assign the code according to the timeline, or when that GCS scoring was solicited, was performed. Assign code R4024, okay, with a hyphen, because you have to assign the last character, right? Glasgow Coma Scale total score when only the total score is documented in the medical record and not the individual scores. So this is very clear, guys, that you can only assign, or you should only assign the R40.24. And when you check the tabular, guys, there's further instruction. When the total score, like this one, up to 15, right, is already established. Do not assign score for each, each, say, test that the medical person is conducting or has conducted. So only assign the GCS score if you are already, or if you have seen already that the total score was already established. Okay. Okay, if multiple coma scores are captured within the first 24 hours after hospital admission, assign only the code for the score at the time of admission. ICD-10-CM does not classify coma scores that are reported after admission, but less than 24 hours later. Okay, so this is very clear, guys. You only assign the coma score when the patient was admitted at that time, because patient can be in the state of coma for more than 24 hours. So we don't, of course, there are reasons why sometimes doctors would, perform tests while patient is still under the coma state, right? So the guidelines are clear, saying that you only assign the score or the code for the GCS score upon admission, okay, within the 24 hours of admission. Okay, so what's next here is death non otherwise specified, or death NOS. Let's read this, guys. Code R99, ill-defined and unknown cause for mortality, is only for use in the very limited circumstance when a patient who has already died is brought into an emergency department or other healthcare facility and is pronounced dead upon arrival. It does not represent the discharge disposition of death. There are two things that are being talked about here, guys. So, of course, death is death, right? There's nothing else to expound on that. But the assignment of the code is dependent on when did the patient die? Did the patient die outside the hospital, or did the patient die within the hospital? So that code R99 is only used when a patient was brought to the hospital already dead. And of course, there are many instances where, a patient had got involved in a massive accident and died on the scene, died on the spot, right? Still, patient was brought to the clinic or to the medical facility. The code you are to assign if a patient came in dead is R99. If a patient died in the hospital, you are not to assign the R99. Okay, so very clear, guys. Do not assign R99 if a patient died in the hospital. That's what the guideline meant about death disposition, okay, or discharge disposition. Discharge disposition dead, it is, the code is different. I mean, the R99 code, this one right here, is not applicable.